Hi, I'm Dr. Manwani, and I'm from UCLA All of You from the Rheumatology Department, and I'm presenting regarding a curious case of arthralgias in an axe thrower. So this case is about a 29-year-old gentleman that came in with 6 weeks of polyarthralgias. He had pain starting initially in his left ankle, and then it progressed to involve both of his knees, and he was having difficulty ambulating, which is what initially brought him into the emergency department. The emergency department saw him and noted that he had swelling on both of his knees and ankles, so they asked rheumatology to further evaluate him. On review of systems, when we saw him, he also endorsed that he had pustular lesions on his face that had been there for several weeks, as well as swelling on the back of his scalp that had occurred after he'd bumped his head on a cabinet 8 weeks prior. On review systems was negative for any fevers, chills, any other systemic symptoms, any history of drug use, any new sexual partners. In terms of social history, he was born in Canada, Toronto, and he had recently moved to California to continue his axe throwing career. The rest of his social history was largely negative for any toxic behaviors. So we asked for more of a workup, of course. His initial labs were largely unremarkable, so his CBC looked okay, his platelets were slightly elevated, and his chem panel looked completely unremarkable. We asked for more imaging, as on his physical exam there were several abnormal findings. So as you can see right here, this is a left hip flank. There's a draining abscess that we noted on exam. And then he had these wart-like lesions all over, so they're also inside his mouth, and then on his wrist, and his finger, and all over his face, which he thought had been acne, so he hadn't even mentioned as part of his complaints, actually. And then he had significant swelling of his left ankle. So we then subsequently, while he was in the emergency department, did a punch biopsy of the right wrist, and then we also asked for more imaging. Imaging of the lungs revealed a right upper lobe cavitary lesion right here, and then imaging of the scalp also noted that there was a lytic lesion of the posterior right parietal lobe. So you can see how significant this is just on imaging. You can see all the fluid that's collected outside of the bone. And then the imaging of the flank revealed that there's a left iliac crest lytic lesion that extended into the adjacent tissue. So it went all the way to the surface of the skin. So initially our thought process, even though gout was on the differential for the ED when they consulted us, we were highly concerned for infectious disease, including a fungal infection. So we asked for expedited staining with GMS and PAS, and it revealed that there was spherical double contoured fungal yeast, which was consistent with blasto, which is a very rare case for us in California. The rest of the workup that we had done showed an ESR that was elevated to 75, CRP of 264, RF was elevated to 16, and then a urine histo, which was over 25. However, it should be noted the histo antibody was negative, quant gold was negative, HIV was negative, and hepatitis panel was negative. It was concerning that the urine histo antigen was positive, but after discussing with infectious disease, it is actually the urine histo antigen can be falsely positive in other fungal infections, so that was kind of a little bit of a red herring. It's actually consistent with blasto. So what happened with this case, the gentleman initially got an LP to make sure there was no CNS involvement, given that he had such a fluctuant mass on his scalp. The LP fortunately was negative and the cultures were negative, so initially he was started on IV ampho for the concern for CNS involvement, but that was quickly de-escalated and he was continued on itraconazole, and he was discharged on PO itraconazole, which he's going to need about 6 to 12 months. At most recent follow-up, he's been doing well. He's had regression of some of these lesions, and he hasn't had any more lesions on his face. Those have resolved. All of his skin findings have been gone, and he's doing much better. So he'll only need monitoring for at least a year out. In terms of the relevant points of this case, just to go over briefly, as we know, blasto is a thermally dimorphic fungi, and it can present with a wide range of clinical manifestations in both immunocompetent and immunocompromised patients, which is important to note because this patient was a young, healthy, immunocompetent patient. And it usually, the typical profile of who it involves or presents with is the typical patient is a middle-aged male who participates in outdoor recreational or activities. So just the points of this case is blasto can be a difficult diagnosis to make without a high level of clinical suspicion. It's something where you need early acquisition of tissue. That really helped us with the staining because the culture took several weeks to come back positive. So that really helped us with treating and identifying and treating him at an expedient manner. And it also involved multi-specialty work. We had consults from ID, pathology, and of course us as well, as it can present in multiple systems and can present in ways that can mimic other fungal, malignant, or autoimmune diseases. So, yeah, thank you.